Revenue in a behavioral health practice rarely vanishes all at once. Instead, it slips away quietly. A week of billing ages past timely filing limits while your team is tied up with daily patient crises, and the money simply disappears into the shadows. The data shows us exactly where this bottleneck forms. Right now, the average behavioral health practice currently carries 65 to 75 days in accounts receivable. This chart compares that industry average against the operational target of high-performing practices across all specialties. Those top performers aim for a much tighter 30 to 45 days in AR. The delta between the industry average and where it needs to be is entirely trapped cash that cannot go to payroll, rent, or growth. Zooming out to the macro scale, the financial damage is measurable. A 2026 Kodiak Solutions analysis tracking net revenue leakage, money providers earned but failed to collect, found a 25% increase in a single year. Across healthcare, that resulted in $48.4 billion in completely uncollected funds. This widening gap in collected revenue is not a failure of individual staff effort. Your billers are likely working as hard as they can. The trapped cash is the result of a structural problem baked directly into how behavioral health billing operates in 2025 and 2026. Behavioral health practices are caught in a mathematical squeeze, starting with soaring patient volume. According to HRSA data, 16 million U.S. adults had a mental illness in 2024, yet nearly half of them received no treatment. That surging volume creates an immediate clinical bottleneck. The national average wait time for an appointment is now 48 days, and 6 in 10 psychologists are no longer accepting new patients. But the clinical strain is only half the equation. We have to look at how payers are responding to this unprecedented surge in claim volume. This graph maps that exact response. As the patient demand curve rises, payers are pushing back with aggressive resistance. The industry-wide initial claim denial rate hit 11.8% in 2024, and by 2025, over 41% of providers reported denial rates higher than 10%. The pressure from specific payers is even more severe. Medicare Advantage plans alone increased their denials by 4.8% in a single year. Every point of denial carries a direct financial penalty. Industry estimates show it costs between $25 and $118 just to rework a single denied claim, eating directly into your margin. A maxed-out clinical capacity combined with aggressive denial tactics creates a lethal environment for a practice's cash flow. Continuing to rely on traditional passive AR management under these conditions is now a massive financial liability. Let's look at why behavioral health AR is uniquely complex compared to general medicine. This flowchart illustrates the payer carve-out problem. A commercial contract doesn't grant access to that payer's behavioral health network. Pathways fragment into separate credentialing applications. If a front desk worker misses this detail during eligibility verification and bills the parent commercial plan, the practice faces a 30 to 40% higher denial rate in the first 90 days. Then there is the clinical documentation burden. Behavioral health progress notes, treatment plans, and medical necessity determinations must pass through payer standards that are inconsistently enforced and constantly evolving. This is where general medical billers fail. Without specific training on behavioral health CPT codes like 90837, 90832, and H0015, they submit claims that look completely clean on the surface, but fail immediately during payer adjudication. Behavioral health AR is a highly distinct specialty. Applying general medical billing tactics to psychiatric codes structurally guarantees rejections and lost revenue. The workflow in most behavioral health practices relies on a deeply flawed staffing model. Typically, a front desk coordinator or part-time biller tries to squeeze AR follow-up into the gaps between scheduling patients, answering ringing front desk phones, and entering endless EMR data. This approach ignores the reality of the portal problem. Managing 3 to 5 major payer contracts requires juggling completely separate logins, interfaces, and adjudication timelines for systems like Availity, Navinet, and UHC. Add the authorization problem. Billers must track varying session limits and concurrent reviews for each payer. It is an administrative maze so dense that 93% of physicians now report care being delayed by these exact requirements.
When the front desk inevitably gets overwhelmed by immediate patient needs, the AR queue gets dropped. The immediate crisis always overrides the aging claim. This creates a dangerous single point of failure. When your one dedicated in-house biller goes on vacation or calls out sick, the entire revenue cycle freezes in place. Multitasking is the enemy of AR recovery. Without dedicated, uninterrupted focus, minor issues go completely unworked, and recoverable 60-day claims slide quietly into unrecoverable 90-plus day write-offs. Let's break down the true financial math of the in-house staffing model.
Hiring an in-house biller for behavioral health AR starts between $55,000 and $75,000 a year before you add the blocks for training, benefits, and paid time off. That high upfront cost comes with extreme volatility. Billing and coding roles suffer from the highest turn rates, and every time a biller leaves, the practice loses between $9,000 and $12,000 to recruit and train their replacement. The most expensive variable is inexperienced staff failing to recognize structural errors. An expert spots a recurring modifier 95 rejection in week 1, but a stretched in-house generalist lets that systemic denial loop run for months. The math is clear. The in-house staffing model forces practices to pay a premium of upwards of $80,000 for a fragile system that still leaves them stuck with an 11.8% average denial rate. The practices currently achieving optimal AR metrics all follow a strict set of operational rules. The first rule is simple. AR ownership must be entirely separated from front-end claim submission. Second, they enforce the 48-hour rule. Every denial must have a logged reason code and a next action assigned within 2 business days to stop the compounding cost of rework. Third, they audit strategically. This visual shows an AR aging report segmented by standard 30-day buckets. Instead of chasing individual claims, experts analyze the 90-plus day bucket by payer to trace stalled claims back to a single systemic root cause origin. Artificial intelligence makes this level of analysis scalable. AI layers continuously check claim accuracy before submission and flag those systemic denial patterns automatically. AI smart routing then directs those flagged claims to follow-up specialists based on the specific payer, the exact age of the claim, and the probability of recovery. The highest value work gets done first. Reaching a target denial rate of under 5% requires treating accounts receivable not as a shared administrative chore, but as a systematic, technology-enabled science. A growing number of practices are achieving this by removing the in-house AR queue entirely. As this graphic illustrates, they outsource the work through a secure data bridge, bringing a dedicated team of specialists directly into their native EMR. This is the exact structure of the Staffingly model. Instead of bouncing your claims through a shared pool of anonymous agents, Staffingly assigns a single AAPC or AIHMA credentialed caller who learns your specific payer mix, your workflows, and your patient population. This side-by-side gauge visualizes the economic contrast. On the left, the fully loaded $75,000 in-house cost sits deep in the red. On the right, Staffingly operates at $399 per week, roughly $20,748 a year, sitting comfortably in the green with zero benefits load and zero turnover cost. Deployment is rapid. Practices establish secure EMR and payer portal access within 48 hours, and the dedicated team goes completely live in 14 days under a risk-free pilot scope. The compliance infrastructure is fully established on day 1. Operations are protected by SOC 2 Type 2 and HITRS-aligned security protocols, utilizing encrypted VPN access across over 40 major EMR platforms. Surviving the margin squeeze in behavioral health requires moving past the generalist in-house model. Treat your revenue recovery as a strategic function handled by dedicated experts. Evaluate the math for your practice and be